David B. Hogan from University of Calgary and Molly Cole from the Alberta Gerontological Nurses Association. Dr. Hogan is a specialist in geriatric medicine. In 1990, he moved from Nova Scotia to the University of Calgary, where he holds the Brenda Strafford Foundation Chair in Geriatric Medicine. He has participated in a number of national initiatives, including the development of guidelines for the assessment and treatment of delirium in older adults that were sponsored by the Canadian Coalition for Seniors' Mental Health. Molly Cole is a clinical nurse specialist in gerontology who has practiced in both acute and continuing care settings. She has been an active member in Alberta Gerontological Nurses Association for more than 20 years and now serves as the provincial president. She is currently employed with Alberta Health Services Senior Health Provincial Team, helping to establish a provincial cognitive impairment strategy, including a provincial delirium order set and patient teaching materials.
Welcome. I'll start off, and then Molly will be doing the last half or second half of this presentation. So the 7 objectives for the morning are listed: to define delirium and the subtypes, to look at risk factors for development of delirium in older adults, talk about the prognosis and outcomes, list common causes of delirium, and then talk about nursing interventions to help prevent the development of delirium, talk about methods of assessing for delirium in older adults, and hopefully incorporate that as a routine part of your nursing care. And we'll be focusing on the confusion assessment method. And finally, describe nursing interventions for the management of delirium. The focus will be on acute care. So we'll start off with a few questions. One is, what is delirium, and what are the features of it? And the second question is, what are some of the important risk factors predisposing and precipitating for the development of delirium? And we'll start with a story of an older client. The setting is acute care, and the person we're talking about has been in for a bit over a month. Here we go. And you're involved in her care, and she has an altered level of consciousness, and that's been going on for about 5 days. She varies from being drowsy to being agitated, and her family are quite concerned about her because they feel she's confused. She's 81 years of age, and when she came in the hospital, she was living alone. She did come in through emergency room with some weakness on the left side and numbness on that side as well. In the emergency room, she was found to have evidence of impaired renal function. Her creatinine was high, about 2 to 3 times normal, and her potassium was also elevated. She had a low blood count or hemoglobin, and she also was found to be in rapid atrial fibrillation. She was admitted, and after admission it became clear that she was having restful leg pain and had ischemic changes of her leg. So her past history is extensive. She's had heart failure and atrial fibrillation and all the other things listed there. So clearly she has multiple morbidities, multiple conditions, multiple diseases. The question you might want to ask now is she at high risk for delirium? Why would she be at high risk, or why not? What should be part of your baseline evaluation of this newly admitted person? Is there anything you can do to decrease her risk now of developing delirium? Now we'll go back to the case story. So after being admitted to hospital, she was treated with multiple investigations, which of course is at par for the course now in hospital. An imaging study of her head showed a small stroke, a lacunar stroke. She was seen by vascular surgery. She had an angiogram done, and amputation unfortunately was recommended, but she declined. And in dealing with her pain, she was given analgesics. Her kidney function and her potassium both normalized, but her hemoglobin remained low. Her diabetic control wasn't difficult. She was not on insulin and any oral agents, and her sugars were less than 10. From a cardiorespiratory standpoint, her atrial fibrillation slowed down. Her ventricular response came down to about 80. Echocardiogram showed pretty good cardiac function. She was put on anticoagulants and was in good control. Her INR was 2.3 about 3 days ago. Her chest x-ray, when she came in, looked like early failure, but then that cleared. But the last one suggested she might have some inflammation or infection in her left lower lobe. So in hospital, she was dependent for all her basic activities of daily living, including in being incontinent of urine, and she was catheterized. She was mobile for only short distances with a walker. And the nursing notes, when you review them over the last few days, she was stated to be confused intermittently. While in hospital, she was given a tour of the hospital and was transferred 4 times. And the discharge plans were probably not to go home, but go back home with her daughter. But she wasn't at that point yet. The day you saw her and you're involved in her care, she thought she had been there for about 2 weeks, not the month that she had been there. She said she was having some left-sided chest pain, and you wondered if it might be related to the changes on her x-ray. But she denied any leg pain, and she also denied having any peripheral vascular disease. She had no recollection of that. And she wanted to go home today. So next thing you did is look at her medications. And we're not going to talk about them in detail. The important point is that she's on a lot. And when you're on that many medications, the chances of having adverse effects is extremely high. The ones you might be particularly concerned about with regards to her cognitive state would be the morphine that she's taking, the amitriptyline that she's taking, the oxybutynin she's on for her bladder, and you'd also wonder about the PRNs listed here and how many of them she might be taking. You also might be wondering about what drugs she stopped, and she did stop lorazepam and also was on morphine syrup, which was stopped rather abruptly. So other questions which might come up now would include what information in the history or physical examination would you want to gather at this point? And then another one is you might have a suspicion she's delirious. But how would you diagnose it? And what else would be in that differential diagnosis of delirium? And if she is delirious, what type of delirium do you think she might have? What subtype? And finally, what might be contributing to delirium in this lady? Well, if we move on to physical examination, her vitals were unremarkable, except her blood pressure did drop quite a bit when she went from sitting to standing. And her mouth and axilla were dry, so you'd wonder about dehydration. Her lungs were fine, her heart sounds were fine. She did have signs of her peripheral vascular disease in her lower extremities. And she did have what's called myoclonic jerking. Those are intermittent movements of the muscle where a limb will flail up, which is often seen and confused individuals suffering from delirium or advanced stages of a dementia, but nothing else. And when you talked to her, attention tended to drift, and you did an abbreviated minimal state examination. You left out the parts where you have to do writing or where you have to ask her to fold the piece of paper. And she had problems. She had difficulties with orientation. While she registered the words, she could not recall any of them. Had some trouble spelling the word world backwards. So on abbreviated minimal state, her score was 14 out of 24. So moving on, and we're going to come back to these points in the course of our presentation, is you might ask here, what investigations would you like to perform? And if you're involved in her care, how would she be most appropriately managed? So we're going to start now with the kind of meat of the presentation. But I wanted to put things in context and maybe help you think about a patient or a client you may have dealt with recently. So these are some of the criteria from the Diagnostic and Statistical Manual for Diagnostic Criteria, the DSM-4, for delirium. The first is that there should be a disturbance of consciousness, which they further elaborate as saying this is a reduced clarity of awareness of the environment with reduced ability to focus, sustain, or shift your attention. And that's the main feature, that's the presenting feature. Second is that there is a change in cognition. and that may present itself as a problem with memory, evidence of disorientation, or problems in language. If you don't have cognition, you would also be looking for evidence of a perceptual disturbance. That couldn't be better accounted for by, for example, dementia or some other diagnosis. Perceptual disturbance would be things like delusions and hallucinations. The third feature is that this disturbance develops over a short period of time, usually hours to days, and tends to fluctuate in the course of the day, and tends to be worse at night. There was a movie that was released in 1945 called The Lost Weekend about a person who was going through alcohol withdrawal, and there's a line from it saying delirium is a disease of the night. So often you see more delirious manifestations at nighttime. And that's why it's always very helpful to look at the whole nursing record and see what's recorded in the evenings and at nighttime if you're seeing a person during the day. The final feature is that there's evidence from the history, physical examination, or laboratory investigations that the delirium is due to something, a general medical condition, an intoxication from a drug or other type of substance, withdrawal from a drug or a substance, or maybe from multiple etiologies. And finally, there's a group that you know they're delirious, but you can't really put your finger on it. It's important to realize that in older patients, delirium is often multifactorial. That means more than one cause, but also it's not uncommon to find no clear cause. Now, to shorten this down, and how would you operationalize all this information, I think you'd be thinking of delirium as someone presenting with altered level of consciousness, and that may be drowsiness or could be agitation. They would have a poor attention span. They might be wandering if they're mobile. They would have disrupted sleep cycles, and they're easily distractible. You may see disorientation and memory deficits in your interaction with them, and they also may be having hallucinations. The motor signs could be agitation, myoclonus, this jerking that I mentioned earlier. Asterixis, that's a flap you sometimes would see where people try to hold their hands up and they kind of drift down, then they snap them back up. And they may be picking at non-existent objects, like under bed sheets, like bugs crawling. It's often possible to demonstrate something that predisposed a person to delirium and also what might precipitate it, but remember that's not always the case. So the forms of delirium are listed here. There's a hypoactive form, the hyperactive form, the mixed, and other, where there's really not a major change in the psychomotor activity. The one that is missed tends to be the hypoactive. These people are sluggish and sleepy and lethargic, and they don't cause a disturbance. They're not swinging from the chandeliers, so they're not picked up. They may be seen as depressed or showing poor motivation. In overall cases of delirium in older persons, the prevalence of this type is from about 20% to about 70%, usually a third to half in most studies. The ones that are picked up are the hyperactive delirium. They're agitated, they hallucinate, they're inappropriate. And then there could be mixed, where they would have a combination of the two. And finally, as I mentioned, there could be the other form, where there's really no change in their psychomotor activity. And we'll move on to talk about how common this condition would be. And we're going to be focusing, as I said in my earlier remarks, on acute care. Studies of older individuals in the community would indicate that it's about 1% to 2% older individuals would have a delirium in the community. And over time, the incidence would be in the range of 10% over 3 years, maybe up to 13%. Particularly if they have a pre-existing dementia. If you look at long-term care facilities, it's been poorly studied, but overall the prevalence is felt to be about 10%. Prevalence means if you go around on one day and saw 100 people, you'd find about 10 having evidence of delirium. Emergency room at presentation, about 10%. In the hospital, at the time of admission, 10 to 20% of older people will have a delirium, and during their stay, another 5 to 10% would develop delirium on medical units. Very common after surgery, 10 to 15%, and for particular types of surgery, like surgery for a hip fracture, very common, 40 to 50%. And there are very high rates in special populations, like those receiving palliative care, dying from a terminal illness, a cancer, 80% plus, ICU, 70% overall prevalence, and among those with dementia or hospitalized, about 2/3 will develop a delirium during their stay in hospital. Now, if you think of risk factors, they're a mix of predisposing and precipitating factors. And I think you might imagine about an older person as being vulnerable to a various degree to development of delirium, and then they're exposed to something that would be a stressor that might precipitate delirium in them. So it's a mix of their vulnerability and the precipitating factor. And highly vulnerable individuals will take very little of an insult to develop a delirium, while if you're more robust, will take a greater insult. The factors, precipitating, do overlap, and whether they're predisposing or precipitating often relates to when it happened, when it occurred. This is just a graph showing the same information. So if you look at high vulnerability, you can see that a low level of insult could lead to a delirium, while if you have a low level of vulnerability, that's the bottom right-hand box, it would take a higher level of insult to lead to a delirium. Now, predisposing factors, a number of them are straightforward. They're demographic, increasing age, particularly being above the age of 70. Men seem to be more likely to develop delirium than women. The strongest risk factor, the most consistent one, has been pre-existing dementia or cognitive impairment. So if you have a dementia, you're at very high risk for developing a delirium. Past history of delirium increases your risk of developing delirium later on with some insult, and depression also increases your risk. Functional impairment, a degree of disability, would increase your risk. If you're from long-term care, you're at higher risk. And sensory impairments, vision and hearing, would increase your risk. Dehydration and malnutrition are risk factors. And you could look for evidence of dehydration in blood work by looking at the ratio of the urea and creatinine. And if it's greater than 0.1, that would suggest a person is dehydrated, because you tend to reabsorb urea, and the ratio changes when you become dehydrated. And the number and the severity of coexisting conditions would increase your risk of developing delirium. As for precipitating factors, you really worry about medications, psychotropics and narcotics, drugs with anticholinergic effects. The number of medications, the more you're on, the more likely you are to run into problems. And withdrawal from medications and also substances like alcohol could be precipitant for delirium. Intercurrent illnesses like an infection could precipitate delirium in a predisposed individual. Surgery, as we talked about earlier. If you have changes in your electrolytes like an abnormal sodium or potassium or glucose, particularly if they're preoperative abnormalities, could be a precipitating factor and evidence of dehydration. Being in an intensive care unit, having restraints used, and being catheterized are environmental factors which might precipitate delirium. And sleep deprivation, stress, inadequate pain control would also be. Another one I want to mention that's not listed here is frequent moves in a hospital. That's also a clear precipitant, and that might be something we could do something about. Now, next slide just tries to give you ways to differentiate depression from delirium from dementia, looking at onset and duration, the course of the illness, what their consciousness might be like, what they would be like with regards to attention and memory, and their mood or affect. And I won't go through them, but please take a look at them when you have some time. We often spend time trying to differentiate the 3Ds, but I think it's important to know that the distinction often isn't that clear-cut. Depression and dementia, we know, often coexist. And delirium and dementia often coexist, with delirium being superimposed on a dementia. As I mentioned, dementia is a risk factor for delirium. But remember, abrupt changes are not in keeping with most uncomplicated dementia, so if there's an abrupt change, think of delirium. And in delirium, those with dementia, the disturbance appears to be greater with regards to the level of consciousness, and they tend to have more cognitive issues as compared to delirium in people who do not have underlying dementia. Also, over time, it's been found that if you have a delirious episode as an older individual, you're at higher risk of developing dementia over the next year or two. So delirium is a risk factor for dementia. Depression and delirium can also coexist. And as I mentioned, depression and depressive symptoms are a risk factor for delirium. And hypoactive delirium can be easily confused with a depression and vice versa. Now, what are some of the outcomes in hospitalized older persons with delirium? They have a longer length of stay. Their mortality is 3 to 5 times higher as compared to non-delirious older patients. Their in-hospital mortality rate would be 20% plus, which is similar to what you would see with acute myocardial infarction and sepsis. So it's a very dangerous marker for an older person. At 1 year, a third to nearly half of older delirious patients will have died. They have an increased risk of being institutionalized at discharge from hospital and also at 1 year after leaving hospital. It's also a risk factor for development of functional and cognitive decline. As I mentioned earlier, it's a risk factor for delirium. If you have a dementia, for example, from Alzheimer's disease, it appears to accelerate trajectory or your course, and you tend to have a more marked decline. And there might be incomplete recovery from delirium. This is sort of the sad fact that is becoming more increasingly recognized recently over the last few years, is that it may not entirely clear, and the person never quite gets back to their prior capabilities. And if you have a vivid recollection of the delirious episode, that can lead to a post-traumatic stress disorder in some individuals. We did do a study here in Calgary a few years ago looking at cognitive impairment in hospital. And we found that delirium affected nearly a quarter of all hospitalized patients in Calgary who are 50 years of age or greater. Their in-hospital mortality was 11.2% compared to 2.9% in those people who had normal cognition. The risk of falling in this group was 14.6% during their stay in hospital compared to 1.7%. Their length of stay was over twice as long, 21.3 days versus 8.3 days. And they were much less likely to be discharged to a private residence on leaving hospital, 48.8% compared to 87.2%. So I'm just going to finish off and turn it over to Molly, but just make a couple of last points. I hope you realize that delirium is common, that delirium is serious, and that there are risk factors for delirium. And even at this point in our presentation, I would hope you could start thinking about things that could be done to intervene and maybe prevent the development of delirium, and after it hits, what could be done to attenuate its impact on a patient. Molly.
Thank you. So for the remainder of the presentation, we're going to focus on these 3 areas: prevention, recognition, and management. And I'm really wanting you to think about focusing on those patients that we've identified as being at risk for developing delirium, and looking at how we can do comprehensive and regular assessments of them, and what strategies have been found to be evidence-based to help prevent delirium. And, you know, this is the piece that I think is kind of new to some of us as practitioners. 20 years ago, when we were talking about delirium, there was a sort of a sense of fait accompli, that it was going to happen. Oh, well, too bad, so sad. But I think now that we're recognizing that there's a whole lot more that we can do, and most of the interventions are nursing-based, and that we can be much more diligent at preventing at least some of the delirium, certainly not owning all of the delirium, but recognizing that we do play a role in that. So I want you to think about who is at risk, so you can get a mental image of the clients that you're providing care for. And we've been talking in the acute care setting, but certainly these would be the same clients in your continuing care settings or your home care settings who are at greater risk of developing delirium. So as we've been focusing on the older adult with some underlying cognitive impairment, it's that person who requires some help with their activities of daily living. Often they have hearing and vision problems, and they're probably not your most ferocious eaters in your setting. You know, they're the ones that you really have to encourage them to have another sip of fluid and another sip of food, or a bite of their food. And as Dr. Hogan pointed out, they're usually, their med profile is extensive, and they're often on some psychotropics, and their underlying medical conditions are a bit of a challenge as well. So focusing our efforts on these people will reap our greatest rewards. So the components of a delirium prevention strategy are looking at maintaining, so this is before the delirium develops, making sure that we're being vigilant with our orientation strategies, making sure the person can see a clock, has access to a calendar, and has regular visits. Now this could be from volunteers, from healthcare aides, from family, but that the team is recognizing that the importance of keeping the person connected with our current reality, so talking about where they are and what's going on, and sort of having that regular social contact. We know that there is a very high correlation between lack of sleep and developing delirium, and those of us who have had restless nights and haven't really felt quite so alert ourselves the next day will have a small glimpse of what might be experienced by the person who is at risk of developing delirium. So what can we do within our nursing profiles to be helping the person settle better at night? There's evidence that shorter amount of time spent helping somebody sleep so they have improved sleep, so the back rub, the warm drink at night, considering relaxation tapes, and then looking at our care throughout the night. Are we methodically trying to group our activities so that we're interrupting the person's sleep the fewest number of times throughout the night as possible? Or are we in often a team-based orientation having one person go in to change an incontinence product and the next person go in a short time later on to hang the next IV medication? So what can we do to avoid interruptions at night? We know that deconditioning is associated with the development of delirium, so what can we do to keep people up and moving and focus on their maintenance of their pre-hospitalization or pre-illness level of functioning? And then really being diligent about making sure we're doing everything we can to address their visual and hearing deficits. I've been working with a group from ICU, and they proudly tell me that as soon as the patients are admitted to ICU, they send their glasses and hearing aids home because they don't want to be at risk of losing them. And I chirp up and say that possibly if we're looking at decreasing delirium, we might want to make sure they have access to some form of being able to see and hear. So, you know, those expensive hearing aids, maybe we don't want to keep them in the hospital, but what's our alternative to help avoid disorientation from lack of sensory input? So are we using pocket talkers and other devices that are available? And certainly knowing that a hydration protocol is helpful for keeping our patients away from delirium. So there are protocols that suggest that for those who do not have a fluid restriction, that the whole team be aware of the need to offer a sip of fluid every time they go in the room. And more evidence of this nursing-based protocol can be found in the journal reference on the slide, and by Googling or looking up the HELP program, the Hospital Elder Life program, which describes some protocols that would be helpful for putting in place some protocols to prevent delirium. The one that is not mentioned in those protocols, but we certainly know is evidence-based, is avoiding catheterization, especially indwelling catheters, because we know that there's a high connection between the development of a UTI and the experience of delirium. So Dr. Hogan referred to the literature that says that we miss a lot of delirium, and there is evidence that we do miss a lot. Our physician colleagues are known to only identify between a third and a half of the symptoms that are documented by physicians, but nurses, especially for the hyperactive delirium, we're a little better at charting it. If you're in a position to be reviewing charts, you'll certainly see long descriptions of the bizarre behavior that somebody with delirium experiences, but I would challenge us to ask within our own personal practice and within our colleagues on the unit where you're working, how often do we assess and identify the hypoactive delirium? And because they're often not the ones that are quote in our face causing a disruption, we may well miss that they have withdrawn into themselves and are somnolent and not able to interact in an appropriate manner with the environment. So we do miss those people or misdiagnose them as being depressed. We might ask ourselves about why. Sometimes some of you will identify with a case where the client is quite agitated and quite delirious at 2 o'clock in the morning. And when the physician does the rounds at 10 o'clock in the morning and asks about it, we've heard the patient say, "Oh, no, doctor, everything's just fine." So that fluctuating course of the delirium can make it a bit tricky for us to see. So it depends on when you're doing the assessment that we need to have good communication between our nursing team so that we're sharing the attributes of delirium between the shifts so that we can start to see the pattern because of its nature of a fluctuating course. And we do know that with the overlap with dementia, that it becomes really challenging to figure out which are the quote normal behaviors of the person suffering dementia and what are the new behaviors that might be associated with the delirium. So, and we have all, I'm sure, come across staff who have a bit of an ageist assumption that when you get old you get confused because everybody gets dementia. So we certainly know in our practice area that that's not a true statement, but that sometimes delirium just gets lumped in with that assumption that everybody who gets old gets confused, and so we might not be looking for it or making an assumption that it is part of normal aging. I'm not convinced that nurses regularly go looking for cognitive impairment, that I'm not sure that when we do our vital signs, we've been encouraged over the last couple of years to consider pain as the 5th vital sign. I think we should be considering cognitive assessment as the 6th vital sign, especially in those populations that are vulnerable or at risk of developing delirium. So can we consistently build into our nursing practices the assessment that would help us pick up on deliriums in a much more systematic and evidence-based way of doing that? And we'll talk about the confusion assessment method in just one moment. So I think that's the last point on the under-recognition is that often in large urban centers, in acute care settings, the staff don't necessarily know what the baseline is for the person, and so it requires some investigation to go back to the family, to go back to the residence where the person has come from, to say, what was this individual like beforehand? Because what we're seeing is quite a bit of confusion. Is that normal for the person? And families are often recognizing that something is different with their mother or father or the family member, but they may not have the language to be able to describe it to us. And so we might need to be a little more sensitive about how we ask the questions about, is this normal behavior or is this not? And when a family member says to me, 2 weeks ago, Mom was driving to her golf course and managing her own bank account, and the person we see in the bed now is quite confused and unable to interact with us, then that's a really clear indication that there has been an acute change in the person's cognition and a big trigger to us that this is likely a delirium that we're looking at. But families themselves often assume that when the person becomes confused that this must be dementia because they hear a little bit about dementia in the media and they themselves may not have the knowledge to distinguish between dementia and delirium. So I would encourage us to go looking for delirium, especially in those who are at risk, and to find out what that baseline is, and to regularly on every shift use some form of a formalized way of assessing for cognition on every shift. And so some of us use portions of the mini mental status exam. The niche Nurses Improving Care of Health System Elders protocol suggests that asking a client to repeat the days of the week backwards can give you some of the information that you're looking for that will help you make the determination as to whether they can attend to an instruction or a request to do something. The ICU protocol asks the person to tap on the table when they hear the word A or the letter A, so you repeat a string of letters to the person and look for, are they able to attend to the instruction of tapping on the table for the letter A. So these attributes are what we look for in what's considered the gold standard for diagnosing delirium, and certainly our nursing assessments will help contribute to that overall diagnostic algorithm, and certainly encourage us to use the language of the CAM, because when we do charting that talks about the patient being confused, it's difficult to build the case then for our physician colleagues to do the investigations required in the underlying piece to know what's happening if we're not using language that is then well established, that is highlighting the criteria for what the delirium attributes are. So the four pieces that we look for to make the assessment of presence of delirium are the acute onset and the fluctuating course, The inattention, so that's the difficulty focusing on something, and that's where I suggest that it's important for us to use some sort of a formal mechanism for assessing for inattention, because it might be quite easy for a patient to not display that inattention in our just casual conversation with them. Certainly, disorganized thinking is very typical, the rambling, incoherent conversation, and I'll just give you a very brief quote from a patient who, when I spoke to her on Monday, was completely clear. We were having a totally normal conversation, and when I came back to finish the consult with her on Tuesday, it was very evident from the nursing documentation that she had developed a delirium during the night. And when I went to see her, this is what she said. Come on, you've got to help me get dressed because I'm going out for lunch with Wendy and I don't think I'm going to wear my bathing suit. So it was a rapid speech. It was jumping all over the place, the reference to wearing a bathing suit, like none of it made sense at all. So that looking for that disorganized thinking and the incoherent rambling. And then, as Dr. Hogan has described, looking for the altered level of consciousness, anything but alert is a concern. So is the person more agitated? Are they displaying some of the hyperactive attributes? Or are they pulling into themselves and being more hypoactive, which, as we're trying to build the case, is much more difficult for us to identify as being delirium. So we use the mini mental status exam, portions of it less to diagnose the delirium, but as building this case around the attributes of the delirious state itself. So once we have identified that delirium is in place, we want to address those predisposing and precipitating factors. And the other 2 points on the slide we'll get to, but we're going to start with these pieces. So we're going to want to make sure that there's a good history done. Some of it is a medical history, including the psychiatric and recent surgeries. We want to look at medications, especially considering was the person using alcohol. We want to look at their sensory deficits, things that we know to be contributing to the development and worsening of delirium, and doing what we can to prevent them. In the physical assessment, we for sure want to focus on neurological things, hydration and nutrition. Is there evidence of some infection going on? And again, asking the family if there might be any evidence of alcohol abuse or withdrawal. There are known investigations that we would advocate to be ordered to look for the underlying cause of the delirium. And we would also be working with our physician colleagues to look at additional further investigations that might make a difference between the delirium development and the dementia development. And as Dr. Hogan has said, we certainly want to make sure that we're looking at the medications that have been started or stopped or changed, because they may be the they may be the cause of the delirium at this time round. So the medications that are high risk of developing delirium are on this slide. Those sedatives and hypnotics and the narcotics are particularly challenging. The anticholinergics, the ones that we use for the incontinence, and some of the antidepressants also have those anticholinergic side effects, which we know to be contributing to the development of delirium. The opioid cognition, we want, when there's a real balance here, because we know that pain, the experience of pain, can contribute to delirium. So we want to manage the pain in a way that minimizes the development of the delirium from the opioids that we might be giving. So when we do start somebody on an opioid, in addition to looking at their bowel regime, because we all know that there's a high correlation between opioids and the development of constipation, that we also want to be looking at the person's cognition and really trying to minimize the amount of medication to maximize the pain control. So we're using the least amount possible to keep the person as clear as possible but as pain-free as possible. And then also looking at minimizing any other medications that might be along the side that could be contributing to the delirium, such as the psychotropics. And making sure that we really are addressing their hydration needs and using diuretics very cautiously. So again, it's a team approach that we need to do to be managing the medications. The PRN medications are often within the nurse's domain, but recognizing that we have an obligation to do the assessment after we administer a medication that has been ordered. And then once we have done this investigation, then we want to get a treatment plan going as quickly as possible. There is some evidence that there is a school of thought that says basically that when the delirium starts, it's going to run its course. But there's some beginning evidence that if we treat the underlying cause of it, we may shorten or make less severe the symptoms of the delirium. So when the person is experiencing delirium, we want to prevent complications as much as possible. So looking at ensuring that we are keeping close observation of them in the usual medical ways, looking at their mobility and their pain and their sleep, as well as their at risk for harm, and skin assessments, etc. So we also want to keep track of how the delirium is progressing so that we can have our shared observations within the plan so that we're not discharging patients home when they're in the acute confusional portion of the delirium, recognizing that it can take 3 months for the person to return to a baseline cognition. So having some way of tracking the resolution of the delirium so we can contribute to a safe discharge plan being developed for the person. So we need that ongoing cognitive and functional assessments to add to the team's knowledge about how the person is progressing through the delirium. When the person is experiencing the delirium, we want to support them and prevent the complications. Many of the interventions suggested here are ones that we also do to help prevent the delirium. So we want to work with the physician colleagues to maximize their medical conditions, keep their hydration and nutritional status at best possible function, treat any vitamin deficiencies, especially those associated with alcohol withdrawal. We really want to avoid catheterization. And I know in our experience here in Calgary, we often, when we trace back how the catheter got in, the story sort of goes, they came to emerge, a catheter was put in as part of maybe a regular routine of care there. The patient's admitted to the acute care unit, and sometimes it takes up to 3 days for us to start asking the questions about why the catheter was put in, finally get the okay to remove the catheter, and by that time the damage has been done in the introduction of the infection to create the urinary tract infection, followed quickly by the delirium. So really being on top of asking every shift, why does this catheter have to be in? Has it served its purpose? Can we remove it? So we're being diligent about getting rid of catheters, the indwelling catheters, as quickly as possible. And then looking at the psychological supportive care. We're talking more and more to families and finding that they're quite confused about this whole acute confusion that their family member is experiencing, and maybe we can do a better job of inviting them to be partners with us in helping address the delirium. So asking them to bring photos in from home, to have frequent short visits so that, you know, in a whole extended family, they can put the schedule together so that regularly the family member is seeing a familiar face, having the reassurance and the conversations that will help with their orientation strategies, especially in the evening as we're helping to settle people. So really explaining to the family what their role can be in helping to manage the delirium, and reassuring them that in many cases the delirium will improve at least somewhat, knowing that this is an indication that possibly the person's cognition may not ever get back to baseline, but sort of starting those conversations in a way that doesn't lead the family to believe that the home has to be sold and mom has to move to a long-term care facility tomorrow, but how do you balance that and support the family and use the family to help support the client in that situation. We also know that in speaking with those who have resolved from a delirium, that they talk about it as being a very frightening experience. And I think that it behooves us as nurses to use our therapeutic use of self to really maintain a calm environment when we're working with those with delirium, to really reassure and explain what we're doing to people. One patient said to us as he recovered, you know, it would have been helpful to know that you guys were actually helping me, because he had built a belief that everybody was out to get him. Now, there's no evidence for sure he would have believed us, but if he had had nurses explaining to him that we understand your thinking is mixed up, we're doing everything we can to figure out why, we're here to help you, sort of reassuring him that we're on his side as opposed to part of the delusion that he had created that everybody was against him. And I have found the words mixed up to be ones that older adults respond to me because they themselves are worried about the word confused because they think that it means they're getting dementia. And the word mixed up in your thinking seems to be one that has allowed older patients to respond to me to say, yeah, I was a bit mixed up last night. It's a little less threatening terminology when I'm speaking with them. Certainly, we want to look at the environment. I mentioned earlier about making sure we have orientation strategies. I have a secret desire that above every hospital bed in our acute care settings, we would have the name of the hospital and the floor that the person's on and the city that they're in so that there's a permanent reminder to people about where they are. Because I think if you look around any of the hospital beds where you're visiting or working and try to find out how you would know where you are from the closed curtains, it can be a real challenge. So I think we need to do a much better job at giving people the information they need to try to stay oriented. The right amount of stimulation is another piece, and I know that a nursing protocol often has the delirious patient move to the nursing station so that they can have close observation, and that's right where they're likely not to get the best amount of sleep. So it's a real balance between having enough stimulation that the person is not suffering from social isolation, as well as having a sufficient amount of quiet so that they can get the rest required. So trying to balance those two, and as Dr. Hogan has said, trying to avoid room changes. We know that the disorientation that happens in older adults when you move them even from bed to bed. So in your overcapacity protocols, be looking at who else you can move as opposed to the person who is at risk of developing delirium. And as I've mentioned, talking about the sensory deficits and really trying to avoid restraints. We know that when restraints are put on to help prevent falls, which as gerontological nurses we know that that may not actually work in all cases, that the restraints themselves have been shown to have a correlation to developing delirium. So being really vigilant in the use of restraints. That this is a team approach, that we need to work together to share our concerns about the observations we're having with the medical team, with our allied health colleagues, so that we're trying to put together a whole team approach to supporting the person who has delirium, to helping prevent it in those that it has not yet developed, and to calling in consult services where available, trying as much as possible to have continuity of care, knowing that some familiar face is better than having a new face every shift, providing care to people who are already at risk of developing delirium. And certainly on transfer or discharge, making sure that the person, the service that is receiving this person is aware that a delirium has been experienced, because we know that it does not just resolve after the short period of confusion has resolved, that it can take some time for the person to get back to their baseline, and that there needs to be some follow-up required to help with that transition period back. Dr. Hogan's going to just look at the last 3 slides or so, looking at the medical management of delirium.
Thanks very much, Molly. So we'll just quickly go through this because I think this is the least important part of the presentation, but unfortunately it's the one that seems to get the most attention. I always get asked in presentations about delirium about the use of psychotropics. They should rarely be used, and they should only be used for certain situations. Very distressing symptoms on the part of the patient, to allow central investigations and treatment, and finally to prevent harm to themselves or others. Those are really the only reasons for psychotropic. A touch of Haldol is not good for everyone. You should pick one drug and use the lowest effective dose and taper as soon as possible. The duration of treatment we talk about would be 1 week or less. And the dosing, it depends very much on how effective the drug is and whether there's development of any adverse effects. The drugs you use are generally antipsychotics. Haloperidol or one of the atypical antipsychotics are the ones that are most commonly used. I think an important point is the dose. In older patients, the dose of haloperidol we're talking about is 0.25 to 0.5 milligrams, maybe once or twice a day. I still frequently see people put on 5 milligrams every 4 to 6 hours. The exceptions for the antipsychotics would be for alcohol withdrawal delirium or benzodiazepine withdrawal delirium. Here you're looking at benzodiazepines. On the next slide, just very quickly, is an approach for using haloperidol with severe disturbance in setting of a delirium. Gives you an idea of what dose you start with and how you'd escalate up and how you'd kind of titrate that dose. But I'm not going to go into that because of time constraints. I just wanted to make a couple of final words. When I give presentations about delirium to my colleagues, they say, well, that's very interesting. I see delirium is common, but not in my experience, not in my ward. People don't recognize it among their own practice or in their own practice because they're missing the hypoactive deliriums. And they're only picking up the hyperactive ones that are very flagrant. The other thing that I often say is, well, that's interesting, but we know that. We know that we should keep people hydrated. Well, that's true, but you're not doing it. And I think it's much like the checklist approach in surgery. You have to have a very standardized and comprehensive and thought-out approach to these issues and tick the checklist off. Have you given them something to drink? Have you fed them? Have you walked them? We know it, but we don't do it. And I think it's critically important that we don't forget these basics of good care. And thanks very much.
So the first question is, we would like to see evidence supporting the percentage of delirium in acute care. So the reference that this person has indicated indicates actually a higher percentage of delirium at 90% rather than 70% in the ICU.
Well, I never said it was 90%.
No, she's saying she has evidence that it's 90% in the ICU. I think there's a lot of research that is uncovering now our ability to describe the incidence or prevalence of this, and part of it has been not necessarily a shared description of what it is that we're describing. And so certainly the American Delirium Society has been talking about ICU as having higher than we ever expected rates of delirium that they used to call ICU psychosis. So is that the same thing as delirium? I would think so, but maybe it's a case of what language we're using to describe it.
Just to go back, if it's 70% or 90%, I think we'd all agree is high. And different studies have different figures. So I think baseline 70%, and if some studies say 90%, that's fine too.
So this question is also for you, Dr. Hogan, around our challenge to have a clear diagnostic protocol to respond to delirium. Are there any new progresses on brain scans that may indicate acute brain changes that would reflect delirium?
The answer is no. Delirium is a functional neurological problem. It's not a structural neurological problem. You might see predisposing precipitating causes on imaging studies like a stroke, but you don't see delirium on scans. Metabolic scans also have not been extensively studied in this area because you're dealing with acutely ill individuals. It's a very difficult area of research, but unfortunately, no. You can do things like EEG, which show diffuse abnormalities, but you generally don't need that to know that you're dealing with a confused and disturbed individual.
The next question has to do with the setting of delirium in the palliative care setting. And we recognize that sometimes every time you go to treat delirium, you do have to ask about the advanced goals of care for that individual so that we're not overly treating something from a curative perspective when we have moved into a palliative response. But this individual is certainly suggesting that where a symptom reduction would support the person with palliative goals of care, the treatment of the delirium makes great sense. And so he talks about the investigations that are worth doing, especially looking at calcium so that we're preventing the delirium that makes sense.
I just want to mention that the guidelines that we produce for delirium in the elderly have been retrofitted for palliative care settings and are available on the webpage of the Canadian Society for Seniors Mental Health.
And again, a question for me now around the valid and reliable tools to test attention. The Mini-COG is one that has been suggested from the NICHE, the Nurses Improving Care of Health System Elders webpage, as a tool to assess for delirium. There are a number of tools that help nurses track the severity of the delirium. The NUDESC, a nursing description of the severity of the delirium, is another one. So yes, there are a number of tools that we can use. I think the importance is coming up with a consistent method of determining the attributes of delirium so that we can describe clearly to the team that we're assessing somebody to be acutely changed in their cognition, that they don't maintain their attention. And sometimes it's one geriatrician described to me that as the patient talked to me and was distracted in the conversation by the color of my scarf, So she was in the middle of a sentence, and then she stopped talking and said, "Oh, what a lovely scarf." He pointed out that she was displaying inattention because she couldn't maintain the thought of the sentence that she was having with me. She was distracted by the color of my scarf. So it can be observations that we make clinically, but if we're not astute at looking for it, then I don't think we'll find it. So yes, there are tools that are available, and I would direct you to the Hartford Foundation.
Just a couple questions about attention specifically. One test of attention is when you read off a series of letters and you ask them to tap every time they hear A, that Molly mentioned earlier. You can get an example of that series of letters on the MOCA, and you could do that. Also, getting the days of the week backwards is a test of attention. Sequential subtraction is a test of attention, and all those could be used or considered to look specifically at problems with attention. But also, just your interaction with the individual. If they drift off, they lose their focus, that often will give you a good pointer that they're having problems with attention.
The next question has to do with incidence of delirium in assisted living. One study I read indicates that the development of delirium can happen at 3% in community settings, but it is really an acute care story because when it develops in community settings, then the clients are most often transferred to acute care to find out what's going on. And so in addition to arriving in the emergency with delirium, there's also a portion who develop the delirium once they've been admitted to the acute care setting. So this question is talking about sundowning. Oh, and they have a memory of the of their confusion the night before. I hope I'm answering it correctly because I'm trying to read quickly before the end of our time with you. It's quite fascinating that some patients are able to describe to us the experience that they had in their delirium. So they're able to say, I knew that the patient beside me was not really the fishmonger delivering the fish to the restaurant, but I couldn't stop myself from believing it. So there's this fascinating recollection of the delirious, confused thinking, but an inability to challenge themselves to make a difference. Another patient said to me, I woke up and I couldn't find myself, so I went looking for myself in the apartment, and I couldn't find myself, so I went looking in my car to see if I was driving somewhere. So it's like he's having this memory of the delirious experience. So I'm just looking to see if there's...
I think one issue here that brought up the question is differentiating sundowning and sudden dementia from delirium. It can be very difficult. I think you really look at the time course. If it's a consistent problem that's been going on for weeks to months, I think that would probably be sundowning with a dementia. But if it's an acute new problem, then it's more likely you're dealing with a delirium.
Then the last question asked about delirium, and so Jacqueline, I'm going to assume that you're from Alberta because that's the voice that I can speak from. I did make a presentation at the CGNA conference earlier this spring in Mississauga about Alberta's efforts to look at a delirium protocol. We have developed a paper order set for those sites that are not on an electronic health record, and patient teaching materials and a patient poster to remind families to mention to their healthcare provider if they recognize any change in cognition or behavior in the person. As well, we are promoting the use of the Canadian Coalition on Seniors Mental Health staff teaching Trifold, which is available on their webpage, that I would encourage any of you to have a look at as a really comprehensive resource about delirium in older adults. And so the provincial protocol is being rolled out in zones by going through their medical teams first, and we're implementing in each of the zones over the next number of months. Thank you all.
Thank you.